Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe my channel and also please give your valuable comments. Now we were discussing about cardiovascular problems since last few classes, and in the last class we have seen some of the clinical aspects related to cyanotic heart disorders. Now today we will see the complications of cyanotic heart disorders. When compared to cyanotic heart disorders, acyanotic heart disorders will have less complications. Okay, because after all there is no mixing of pure and impure blood, so tissues are not get much affected. Cell is not get affected because cell is receiving partially good amount of oxygen. Although it is not up to the mark, it is receiving. But in cyanotic heart disorders, the tissue and cells will going to suffer. So as a result, there will be multiple complications will be there. Now, one of the major complications related to cyanotic heart disorder is polycythemia. Polycythemia. Now, in cyanosis, the hematocrit of the blood will going to increase because there is pooling of the blood. Because of the pooling of the blood in the sense, in the heart there is a decreased heart supply. Because of the decreased blood supply and decreased oxygen in the blood, the cells will going to increase in size. Cells will going to increase in size. So this increases the hematocrit value, and this leads to polycythemia. So blood becomes heavy due to bulky cells. Actually, what happens is when there is a cyanosis, there is no oxygen supplies to the. When there is no oxygen supply itself, the RBC cannot carry the oxygen itself. So the cells are not receiving the oxygen. When the cells are not receiving the oxygen, now the stimulation is to produce for the more erythropoietic cells, because what body assumes is probably there is no RBC, therefore the cells are not receiving the oxygen. So as a result, automatically an erythropoietin stimulation will take place, and more and more RBCs are produced which are of abnormal size. Anyway, this is one important complication, increase in the hematocrit value. Next is clubbing. Clubbing is another complication. When there is AV channels just below the nail bed will going to dilate and increase because of the deprived oxygen level. This is another reaction to the decreased oxygen level in the blood. The arteries and venous supply, atriovenous supply, which is present just below the nail bed, so they will going to dilate. And there will be a interleakage between AV channels, and there will be a swelling also. This is how the clubbing actually develops. Some other complications are basically related to CNS complication. In the CNS, there may be brain stroke and as well as brain abscess and as well as stroke. The reason why these two complications develop because of cyanotic heart disease in children is a child is having raised hematocrit, and also shape and size of the cell has been increased. We know that. So this leads to decreased blood flow to the brain also, and the microchannels, capillaries, they will get blocked by these bigger sized RBCs. So there will be early chance of blocking and also the stroke. So this heavy blood also leads to stasis of the blood. So there is an increased chance of infection. I already told whenever there is a stasis of the blood somewhere, it's always there is increased chance of infection. It acts as a culture media. So therefore there is every chance of brain abscess. So this is quite common in child with cyanotic heart disease. One more complication is hypoxic spells. So there will be decreased blood flow, and there will be a sudden drop of oxygen saturation in the blood, and it may lead to hypoxic spells. Now another complication is bleeding disorders. Cyanosis can also lead to bleeding disorders, and patient may have thrombocytopenia and defective platelet aggregation due to, again, the stasis of the blood. Because of the stasis of the blood, there is aggregation of the platelets, and we know that thrombocyte, etc. Low IQ, child will also have a low intelligent level. Now repeated infections are also repeated infections, and as well as compromise the CNS function may adversely affects the intelligence level of the child also. Now clinical signs and symptoms, if you see in short, at the onset of the cyanosis, child may have hypoxic spells, sudden desaturation, and also called TET spells, and child is getting fatigue very easily. Okay, the decrease in the exercise tolerance level, and there will be history of squatting. Squatting helps to maintain the cardiac pressure, most commonly seen in TOF, okay, tetralogy of the Fallot. So in the squatting position, when the knee is pressed against the chest, actually this helps to maintain the cardiac pressure. So they always child want to stay in this particular position, okay, because cardiac, this maintains the cardiac pressure. Another is frequent chest infections because of hyperdynamic circulation, the lungs, etc. So we know that, of course, this is quite uncommon in cyanotic heart disorders. In the acyanotic heart disorders, it is quite common. Lastly, there may be cardiac failure. Now, one more important point that we have to understand in CVS is presence of the cyanosis and absence of the murmur and cardiac failure. See, we have to understand this cardiac pathology like this. Now, let us, we are facing a situation where there is a child is having cyanosis, but there is no murmur, there is no cardiac failure. This is possible. Child is remain cyanotic, but no murmur, no cardiac failure. This is possible. How? So this is in a cyanotic heart disease with reduced pulmonary flow. Whenever there is a cyanosis with reduced blood flow, what happens is cyanosis will be always there, but reduced blood flow is there. So therefore, the typical murmur in this condition, in some lesion, which will go into obstruct the blood flow towards the lung, and the murmur which is heard is ejection systolic murmur. Okay. Another condition is pulmonary atresia, where there is cyanosis. Atresia is there, where the cyanosis with the absence cardiac failure, because heart is not functioning more because there is no fluid overload, volume overload. So this valve is atresic. So classically there is no murmur, but as the blood flow is very huge, a continuous murmur is created through the PDA or the collateral pathway. But as there is no any kind of congestion in the heart, there is no volume overload, there is no cardiac failure. So we have to understand this. See, actually what happens is absence of the murmur and cardiac failure, but cyanosis is there. Actually, the first condition, congestive heart, congenital heart problem disease with reduced blood, any conditions where there is reduced blood flow, okay, so murmur may not be there. Okay, but sometimes you can get a small ejection systolic murmur. Another is pulmonary atresia. Again, blood flow is less, there should not be any murmur. But as there is pulmonary atresia, the blood which is collected in the, we are talking about infants or newborn, blood which is collected in the right ventricle. So there is a pulmonary atresia. So now it takes the route of ductus PDA, okay, patent ductus arteriosus. So now PDA again reopen, and the PDA murmur start. Otherwise, it is not the murmur of the particular lesion. Because of the PDA, the continuous murmur can be seen. So these are the two conditions where cyanosis will be there. In the early part, cyanosis will be there, but there is no congestive cardiac failure or there is no murmur actually. Murmur can hurt because of other reasons, not because of the original reason. Another condition is presence of the cyanosis. Cyanosis is there, and also the presence of the cardiac failure, but there is insignificant murmur. Murmur is not seen. This is actually seen in case of cyanotic heart disease with increased pulmonary blood flow. Okay, so where this is possible, this is the most common shunt pathology, and there will be tachycardia, tachypnea, cardiomegaly, and hepatomegaly. Okay, so murmurs are soft, insignificant, and often diastolic due to increased flow across the mitral valve. Okay, so total anomalous pulmonary venous congestion, where the second heart sound is wide and fixed and split, or sometimes truncus arteriosus, presence of the early dashed murmur is there. This is one condition where congestive cardiac failure is there, cyanosis is also there, but there is no murmur. A cyanotic patient and SpO2, we should know about this relationship, cyanotic patient. Another thing that we have to see in the cyanotic patient is SpO2 level. SpO2 level, cyanotic congenital cardiac disease is suspected. When we measure the SpO2 in all the four limbs of the patient, if the difference is more than 3%, okay, then, and both upper and lower limb saturation is less than 95%, so then this is significance. Okay, otherwise it's not significant. When we measure the SpO2 in all the four limbs of the patient, if the difference is more than 3% in upper limbs and lower limbs, and saturation is less than 95%, then it is significant. What you will do in that condition, you go for simple X-ray. First differentiate, is it cardiac or pulmonary? How to do it? Go for the chest X-ray. In the chest X-ray, if you find a lung field infiltration like pneumonia, bronchiolitis, etc., which leads to difficulty in breathing and cyanosis or change in the cardiac size and cardiomegaly, etc. See, when there is a right-sided aortic arch, if it is seen, then CCD is seen in more 90% of the cases. Pulmonary oligemia or plethora may be seen. What is pulmonary oligemia? Amount of the blood flowing into the pulmonary vasculature is reduced. So blood vessels are cleared off from the X-ray. See, simple how the X-ray is useful. Blood vessels are cleared off from the X-ray, so they become narrowed and lungs are more radiolucent. Okay, pulmonary plethora means if the blood flow is increased to the pulmonary area, as in case of shunt pathologies, VSD, etc., due to prominent dilated blood vessels, in X-ray it is visible. Oligemic lung and plethoric lung. Identification of these two is very important. Okay, oligemic lung is seen when the pulmonary blood flow is decreased. Okay, pulmonary plethora is seen when the pulmonary blood flow is increased due to various lesions. This is clearly explains oligemic lung field and plethoric lung field, how to differentiate this. The cyanotic congenital cardiac disease with the pulmonary stenosis is seen in oligemic lung fields. In case of plethoric lung fields, we have cyanotic congenital cardiac disease without pulmonary stenosis. In oligemic lung field, the lung fields are clear, whereas in plethoric lung fields are not clear. They are having more dilated vessels. Then pulmonary atresia with VSD is seen, commonly leads to oligemic lung fields, whereas TGA commonly leads to plethoric lung fields. Critical PS will be seen, TAPVC will be seen. Like this, different types of difference are there. So we have got some of the common cyanotic heart disorder, for example TOF, tetralogy of the Fallot. This is the most important clinical condition with the cyanosis. The components of the TOF are left ventricular hypertrophy, transposition of the great vessels, and pulmonary stenosis and ventricular septal defect. Now, two important factors in TOF that we know is whether there is no cardiac failure in this condition, and there will not be any cardiomegaly. Due to left ventricular hypertrophy, in the hard shadow of the X-ray, the apex is pushed upwards and lifted up. So due to right side aortic arch, and there will be radio opacity in the right side of the heart and decreased pulmonary marking and oligemic lung. So this is due to pulmonary stenosis as the blood flow is decreased, and this can lead to the boot-shaped heart in the X-ray. Okay, boot-shaped heart in the X-ray. Another condition with the cyanotic heart disorder is a TGA, transposition of the greater vessels. So this is another condition with the cyanosis. There will be transposition of the great vessels. Aorta will be present in the right side of the heart, while pulmonary artery will be present in the left side. Okay, so all the flow of the blood from the aorta enters into the right ventricle, and blood flow through the right ventricle is more, and blood mixing will be there, and this leads to cyanosis. So in this condition, there will be cardiomegaly, which is mild, and narrow mediastinum due to apparent cardiomegaly, and increased pulmonary blood flow. Plethoric will be there, and this leads to egg-shaped heart in X-ray. Other conditions with the cyanotic heart disorders are truncus arteriosus, TAPVC, etc. So general management is again management of the hypoxemia, management of acidosis, management of hydration, avoidance of the hypothermia and hypoglycemia, and if the heart failure is present, diuretics and inotropics drugs should be used. Another is we will go for prostaglandin therapy in case of cyanotic heart disease. So most of the time prostaglandin therapy is a life-saving in duct-dependent lesions. So we will give the prostaglandin E1 to the patient because it maintains the patency of the duct. So this will going to open the patency of the duct, and cyanosis will going to disappear. You need to keep the duct open till the surgical correction will be done, and usually surgical correction will be done after some time depending upon the patient condition. Now there is one portion is remaining, that is about the cyanotic spell. So that we will discuss in the next class. Thank you very much.